All right, good morning, and thank you for joining the HTFO and Foot Scientific webinar. This webinar will feature an overview on drop foot. We will introduce and explore key features of the Elevate 360 and Elevate Child. We'll have some presentations of case studies and an interactive Q&A. So for the interactive Q&A part, if you were to just type in your questions in the chat, I will read them out and we'll have Dr. Rob and Chris answer them. Our presenters for today, we have Dr. Rob Faux, an orthopedic surgeon, a foot and ankle specialist. He's the co-founder and president of Foot Scientific and the director of research and product development. We also have Chris Hughes, a PhD, who is the co-founder and CEO of Foot Scientific. So today, they're going to be our presenters for today. And without further ado, I'll hand over to Dr. Rob and take it away.
Perfect. Thanks, Steve. I'll introduce myself a little bit quickly. So as mentioned, I am an orthopedic foot and ankle specialist here in the United States. We do a medical school for 4 years, and then we do a residency program in orthopedics. It's about a 5-year residency, and then I spent another year with training in foot and ankle surgery. And my practice, which I'm still very actively involved in, is a fully foot and ankle 100% practice, large volume. I take care of some sports teams and do both a couple of Division I teams and do a lot of foot and ankle work there. And then also kind of take care of the entire gamut in terms of foot and ankle care, and in particular, and kind of pertinent to this discussion, foot drop or drop foot and its many presentations and different causes. So that's helped in the development process for this. And interestingly, the reason that we began this journey years and years ago came about because of my experience early on in practice, where I had a very large number of patients that had foot drop or drop foot symptoms and struggled to get them to wear the braces that were available. Had a lot of complaints, didn't feel like a lot of the compliance was something that I had much control over. And it was interesting because locally, before any of the current alternative braces kind of hit the market, we had an individual, an older gentleman, I think he was in his late 80s, was actually very kind of a shop worker, and he had designed an interesting brace that a lot of my patients started to use, and I would send patients to him because I liked the concept. So to give him credit for a little bit of the idea of the Elevate 360, this came about with a lot of iterations, with maybe a little bit more work scientifically and technologically to develop. But this older gentleman really kind of understood the idea. He had a foot drop himself, designed the brace, and then we got a lot of those braces from him. He then became not capable of being able to do that for us, and so we started to look for alternatives, and there was nothing on the market. So this is the reason that we began producing and working on the development of this concept that we'll talk about today to help patients. And it's really been revolutionary in being able to be both cosmetically pleasing, ergonomically great for athletes, and for patients of all ages. And I think it really augments other bracing, and then in some cases as a primary and only brace for a lot of patients. So it's been a great concept. So what I'm going to do is I'll share my screen. I'm going to go through a quick presentation, and we'll have time for some question and answer work. Let me pull up my work here. Let's see, make sure I've got the right one. Okay, I got everybody able to see the presentation there. Let's see, let me go into start. Okay, has everybody got that on screen? I see a thumbs up. All right, we'll go ahead and start working. So Foot Scientific is the company that I represent here. And as mentioned, I work in a couple of capacities in development and also in leadership in the company. We do work with kind of trying to identify the niches in the foot and ankle space that are not served well by existing products, and really kind of a focus toward patient needs and identifying, regardless of what the product might be and its potential, we feel like we want to serve the patient population. So we'll start with understanding foot drop. So, and either drop foot or foot drop, I think it's said both ways. most common cause is involvement in some way of damage to the common peroneal nerve or its branches that involve the ankle extensors, the anterior tibialis, the anterior musculature. Sometimes the extensor digitorum longus can also assist, and often it's damage in the common peroneal nerve injury, and so they have catastrophic foot drop, but essentially lose the ability to be able to elevate the foot. Often happens also in lumbar spine injuries, where the lumbar spine in the radicular pathway for the common peroneal nerve or for the anterior musculature is injured either with disc disease, trauma, or otherwise. And then the common peroneal nerve can be injured in fractures to fibula, sometimes in external compression. Sorry, I'm going to go back to that. Internal compression, external compression problems like constriction in a cast or a brace, direct pressure from either trauma or from abnormal sleeping, or often in patients that have, for example, a drug-induced comas, or patients that are heavy alcoholics will often come in after a 7 or 8 hour period of time where they were incapacitated, and will come in with a foot drop because of compression. And then a lot of patients will have things like general neurologic conditions like multiple sclerosis, Charcot-Marie tooth disease, or CMT. Currently, hereditary motor and sensory neuropathy is the new name for that condition. We see quite a few of those in our region, just simply because we have a large genetic volume for HMSN. And so I don't know, in terms of my audience, what familiarity is. If I get a little bit more terminology that doesn't make sense, please, raise your hand or let me know. So anyway, these are patients that I'll show on the next slide here. What we're seeing is patients that have a circumduction gait. So you see kind of a rotational deformity, or a rotational gait. I'll show that again, where the foot doesn't come up, and so they'll swing the foot around. That's the circumduction component of the gait. And often limp with the inability to be able to bring the foot forward. A lot of them will do an elevation of the knee to be able to clear the foot or the leg. And then, in terms of severity levels, these are very variable. Some patients get partial injuries. Others will have significant and catastrophic foot drop. And so different braces seem to work for different people. When it's not complete, our hope is to kind of be able to either stimulate the muscles needed in some way, or support them statically with some type of bracing. And then, there's in the market, there are options for stimulation braces. Many of you are probably familiar with some of these, very expensive, but also very technologically interesting in when they are done well, can allow for isolated muscle group stimulation and timing to fit those into the gait cycle to allow for the ankle to elevate during the swing phase of gait, so that it works well. Many of them are bulky. You can kind of see in the picture there at the bottom of the simulation, they will often have a fairly large size and require a little bit of work to try to get the coordination for gait, to be able to have it happen during the proper phase, or the stance phase, the swing phase of gait. But at the same time, once they get function, or if they work well, patients are very happy with these. Expense is really the prohibitive factor here. In the United States, we struggle with just getting insurance to cover any of this, and most patients are paying for this out of pocket. And I don't know if that's true internationally, but I'm guessing in many places, probably not even available in a lot of even first world countries because of that expense. So it's kind of a narrow range of patients that's valuable for. Traditional AFOs come in ground reaction types like this, an anterior shell or a posterior shell with kind of a polypropylene material, and really works basically to resist the plantar flexion drop and to assist through usually kind of a mild spring motion elevation of the foot. Most of these patients will use a leaf spring AFO, which has just kind of spring function within the brace itself. These fit inside the shoe. That's the biggest problem. Most patients that I see complain about these because they just struggle to find a shoe that the brace fits in. This more carbon fiber type variety that you see here in the picture is probably the best tolerated now in our market, just because of that thin foot plate fits in the shoe much better than the traditional AFO that has the kind of posterior elements that are hard to fit, and they kind of push the foot forward in the shoe. They do a good job keeping the foot stable and lifted. They are rigid. Even the carbon fiber is difficult to get patients to adopt because they tend to get pressure against the ball of the foot from the brace. Even if you have a soft insert in the shoe, it still creates pressure against the ball of the foot, and it's uncomfortable over time. So standing in these and then using them over long term, that's always one of the complaints that we see. And then again, shoes are difficult to find, and they can be expensive depending on your market. In the US, this is the brace that's covered by traditional insurances, Medicare, and usually they can get one of these every 3 years. If it breaks, we have to find justification for getting them a fresh brace. But if it's paid for out of pocket, they can range anywhere from US dollars $700 to $1,200, which for a lot of patients is prohibitive in being able to make choices. If they don't like the first brace they get, they're kind of stuck with that. So I'd say this is the brace that kind of converted me to wanting to try to find something different because it's uncomfortable. So we saw some of these types of out of shoe type braces that were developed after our initial attempts and after we kind of had come to market. Most of these didn't exist until probably I'd say we'd had the Elevate brace had been out for a few years before we started to see some of these popping up. A little cheaper options. They surround the ankle, a soft brace. Typically, most of these, as does the Elevate 360. They drop down to the shoe, kind of lock into the shoe in some way, usually the tongue of the shoe or looking to link into the eyelets of the shoe. And they can be used kind of with any severity of nerve damage, but these cheaper versions are probably most effective in people that have some moderate injury but incomplete, so that it assists where they already have a little bit of the ability to elevate the ankle. And the idea is they'll help maintain a little bit of the muscle function rather than fully resting it like a brace does. And so you don't have as much atrophy potential when using those. They're a little bit cheaply made. They don't last long. A lot of these, the Velcro breaks down, and a lot of these other kind of, I think, cheaper versions are nice, but they require frequent refurbishing. So out of the shoe braces, they kind of don't have the stability most of the time. So a lot of times the foot won't get the full support or elevation. That's one of the problems with a lot of the existing competition, I guess. So they're very flexible, kind of showing there in the video. And because of that lack of rigidity, you don't have the ability to really support. So the idea of the Elevate 360 is just a little bit, not a little bit, but a significantly higher level of material technology, a little more rigidity in terms of the layered foam and structural components and stitching and so forth to create something that has enough rigidity to be able to support the lift. So then the idea, and this is the concept, this is the brace in picture here. The BOA company has been very helpful and great in working with our company in making this available for our patient population. The nice thing about the BOA is that it has the power to be able to lift, adjust at different increments. And then the concept is that this goes as far down on the shoe as possible, so that the lever arm and the physics, the vector that we're resolving here to try to create the elevation, as you can imagine, the further down the shoe you can go, the more lift you're able to get, and with less requirement, less pressure against the back of the ankle. And so these you can see some of the elements here. The eyelets, the eyelet devices there, the little hooks. We've gone through a lot of different iterations of those hooks, gone to a device now that I think is durable, relatively straightforward, requires a little bit of initial work to get into the shoe, but once present is capable of remaining as the only device within each shoe until the life of the shoe is done. So it really is kind of a great concept for shoe attachment. And then we'll talk a little bit later about ways we've got some devices that we also use to be able to create eyelets of our own in different parts of the shoe by putting rivets in the shoe to be able to change where that vector attaches. So that allows this to be able to really be adjustable in where the pull and the direct dynamic elevation occurs. So now let's kind of push this further. A little different view of the device, same kind of concept. So it works in typically a shoe that has eyelets is the easiest way to get this connected. The nice thing is it's comfortable because it's outside the shoe, similar to some of the other braces that we mentioned. But this one's a little more sturdy. We think that's one of the advantages, but yet comfortable. So kind of worked hard to get the right contours and the right materials to make it comfortable and durable at the same time. so that it equalizes pressure around the ankle, doesn't force point pressure or anything that it makes it uncomfortable or unwearable. Kind of looking at some of the elements, it's got a one-hand application concept with an easy buckle release, also a connection, has perforations to allow for breathability, warmer climates. And then the material in terms of the lace technology, thankful to BOA to help us with that in terms of finding the material that is lasting and that rarely breaks down. And then just in terms of shoe sizes, it allows the patient to be able to pick shoes using the eyelet creation concept that allows us to be able to connect it to different aspects of the shoe, different types of shoes. So you can kind of see the eyelets placed in the dressier shoes, and obviously this is a concept that you're not going to see a lot, but we do see our patients. I see my patients come in with a lot of interesting shoe styles, including flip-flops and sandals, where they're able to connect it in ways to the shoe that other devices they're not able to connect. If you look here up on the upper right of this image, this is the crocodile device that allows you to kind of basically create a hole in the shoe and then deposit a rivet so that then that can be plugged into the same device that you would put into the top of the shoe. That allows you to be able to put it into the sandal or put it into the dress shoe, shoes that don't have laces. So nice addition. Now, in terms of function, it's easy to put on. A lift can be customized. It's kind of an easy brace to use. Stable and flexible, like we mentioned. So this little video kind of shows the application. So it has Velcro and then a magnetic strap that drops in itself. And you've already got the eyelets in place. So then the cord pops in with just a 2-finger use. And then leaning forward, you can see in the application now, leaning forward allows the BOA to be able to drop, to tighten up, and then nice hold, easy release. So one of the things that's nice is it has a very easy release concept. So the patient just pushes on the button, the ankle drops when they're sitting to make it comfortable, and they're able to dial it back in as soon as they stand back up. Let's see if I can get this video to play without so this kind of the concept here, without the brace, kind of the same video of circumduction gait in ambulation. And then the idea is that the second video kind of shows with brace in place. And of course, it's hidden under the pant leg, which is one of the favorite things patients love, is the invisibility of it. But it allows the foot to swing, reduces or eliminates the circumduction.
Many people experiencing drop foot also experience inversion or eversion.
Concepts here, I'll let you go.
Inversion is where the front of the foot pulls inward or medially. Eversion is where the front of the foot pulls outward or laterally. Both of these shoes are right shoes. To correct for eversion, using this brown shoe, we place both anchors on the inside or medial aspect of the shoe, whether it's a left or a right shoe. To correct for inversion on this gray shoe, we place both anchors on the outside or lateral aspect of the shoe. On most tennis shoes, the eyelets run low enough to place the anchors in sequence on the bottom 2 eyelets. On this example of a left tennis shoe, the black anchors represent where the anchors are placed to correct for eversion, again on the inside, whether a left or a right shoe, and the silver anchors represent where the anchors are placed to correct for inversion. Regarding where you put the anchors, they can be anywhere on the shoe that lifts your foot in the direction you desire. You may want to use an old shoe to experiment with anchor placement, as well as how and where you place the lace. In the end, you'll have a brace that brings the inverted foot into a more neutral position where the lateral part of the foot lifts and is pulled outward, and where the everted foot is placed into a more neutral position where the medial aspect of the foot lifts and is pulled inward.
So some great, the video kind of speaks for itself in terms of the correction or the ability to be able to kind of adjust foot position. But that's one of the unique elements of the Elevate brace, is different in terms of being different than a lot of the outside the shoe brace options, is the ability to make it customizable and adjust the position. And I'd usually recommend for most patients, regardless of whether they have a little bit of eversion or inversion foot deformity, to have them start with the classic application of, an anchor on each side of the eyelets of the shoe. And then if it feels like it isn't getting enough correction, then start working from there to adjust the position of the eyelet position or the anchors, so that then the shoe can be gradually, progressively improved. And this is where I think a prescriber, a therapist, an orthotist can be very helpful in guiding a patient to use this a little bit better. So as we kind of developed the brace, looked at other options, the Elevate Child foot drop or foot solution has really been an emotionally rewarding concept for us as a company, just to see the life-changing element that this has. And I think here's a perfect example. We've got a young man here, and you can kind of, I'll read this, just a patient response on their child's experience. But this is Peter, 5-year-old boy, paralyzed by transverse myelitis at age 6 months. Huge journey to gain as much mobility as possible despite his spinal cord injury. For years, they searched for AFOs that would help him clear his toe when walking with his crutches. For the last 5 years, all they tried were too bulky, too heavy for him. Hasn't had the benefit of any bracing while walking, so he just kind of struggled. And the Elevate brace was brilliant for him. They provided the support Peter needs without all the bulk and weight of AFOs, provide the stretch he needs to keep the range of motion in his ankles, and the fact that he can wear his regular shoes while wearing the Elevate brace is priceless. I cannot say enough wonderful things, and I'm so thankful that we finally have a functional solution that will help our son. So, of course, as a company, we love these kinds of reviews and just the connection with our population. So just a little information on Foot Scientific, but good time for us to stop and be able to answer some questions or kind of go through this. I'm sure many have come up, so please speak up.
One thing I wanted to mention. Oh, sorry, go ahead.
No, I was going to give you that, Chris.
Oh, I was going to mention that that there's quite a bit of dynamic flex in the in the brace. It's not a rigid feel when you're actually wearing it. There's a lot of different mechanics relative to the materials and the shoe that makes it a kind of a soft land and an easy uptake. Along with being able to just quickly release it at any time for tension when you want to sit at your desk, etc. So the comfort issue is, and the dynamic aspect of the lift has been useful, just by the way.
Sure.
Yeah.
Go ahead, Angus. I see you've sort of raised your hand up there. You can either type your question or unmute yourself and ask away.
Angus, have you got a hand raised there, I think?
Yeah, cool. Really amazing invention. Well done, guys. I noticed with the eyelet placement, is it disadvantageous to cross the metatarsal phalangeal joint, like the ball line of the foot? Because if you go distal, will it just start lifting the shoe and like bending the shoe instead of lifting the foot, or is it able to kind of get around that? What's your experience with that?
Yeah, that's pretty much been our experience, and it makes sense that shoes, even starting with a fairly rigid shoe, you're going to get flex from the gait cycle, and so that flex is going to lift that end. I think you get the best lift closest to the metatarsal head or transverse arch of the forefoot. So that's kind of where we recommend placing the lift is as close to that as possible.
Yeah,
and then again with the medial placement, for example, the lateral placement to deal with in-toe or inversion, do you put the eyelets always in a row, or can you have like one more in the center line and one on the lateral side? That's where you experiment?
Conceptually, yes, that's where you experiment. And I would say, yes, start with one eyelet outside of the shoe eyelet. Start with one on the lateral row of eyelets, and then the second one outside is the best place to start, because you've already got a well-fixed, very stable eyelet. When you're looking at putting eyelets outside of the lace work of the shoe, you don't have the natural reinforcements that typically the shoemaker is going to have. So as much as you can place those hooks within existing eyelets, you're going to have a longer lasting solution. So, as soon as you put the eyelets outside of it, you've got a little bit of wear and tear the shoe is going to go through and potentially pull out and maybe reduce the life of the shoe. So we recommend putting one there, one on the eyelet that's existing to start.
Yep.
Yeah.
Are they a screw base, or what's the
They
mechanism
are.
of fixing?
Chris has done a lot of work on the design stuff. I'll let him comment on what that looks like.
Yeah, I should have just brought one here. I have one over here, but it's just there's a washer, and then a screw comes up through the washer, very flat washer. Screw comes up through the washer into the top where the anchor is, and the screw essentially goes through the eyelet, and then the anchor screws onto top of that. And it actually, we haven't had any. I just have not heard complaints about that, and it never touches the shoe because there's already lift. I mean, never touches the foot, so it's comfortable. And in terms of longevity, just haven't heard any complaints about that. So let
Angus,
us
if
know.
you can, sorry,
Yeah,
Dr. Rob, if you can just
example there, Steve.
unshare your screen, then I think there might be a bigger view of this camera.
Yep. Let me stop share there.
Can you see that? So that's the anchor there.
Right.
So
Yep.
very flush. Yep.
And that small little washer, I've been calling it, is it gives us some surface area so that it just maintains a nice lift without ever kind of having a concern of pulling through, which we just haven't had. So it's been nice. So,
Jessica,
the first,
you go ahead.
Thank you. I just had a question. We work in a children's hospital in Sydney, so I'm wondering how small the brace goes, and if it would be suitable for toddlers and the like.
So we we recommend the child brace from a 3.5-inch circumference of the ankle up to about 6 inches. And then the adult brace from 4. Adult brace can go quite small as well, from 4.5 inches to 14, which would be the rugby players and the sumo people, and it works fine for them too. But for the children, yeah, it goes quite small. And in fact, the overlap, it does get smaller, so there's less Velcro to attach it, but a lot of adults, a lot of petite young women or women would or men would like to use the child brace. It's smaller, it has a lower profile, and so it can range to adults if needed. And some people like the hook option. The only it's easy to put in. You don't have to put the additional anchors in. And it tends to be just as sturdy. We just wanted to be extra careful with the larger people. So,
Yes.
in terms of
and sorry, just confirm you said 3.5 inches to 6 inches for the child size.
yeah,
Correct.
For the circumference?
yeah, it can grow. It can get very, very small.
Yeah.
So yeah,
That's great.
Yeah.
Thank you.
because it wraps quite tightly. And by the way, if there's extra, it can be trimmed. There's not a lot of extra flap on
Yes.
both the adult and the
You
child.
can see where the seams, or not seams, but just kind of the separations there allow for some careful trimming of the brace to shrink it down if you need to overlap it, or if it's too much overlap.
Also, just not to leave the child, because I would like to stay there if you'd like, but just really quickly with the adult brace, the buckle that goes around, if it's a fairly small ankle, the buckle's really not needed. You can cut that off, and it just makes it easy because the Velcro is very, very sturdy. And I maybe shouldn't preach that, because we want to be extra careful, but yeah, it's just an extra.
Pants over vest, which is kind of the way we've always approached things, is we want something that's not going to fail. So we're wanting solution A and B combined to make it work and last for our clients. Let's see, Angus, if you get your hand up again, or is that?
Sorry, yeah, me again.
Yeah.
I'm that guy this conference, because this is really
I love
exciting.
That's great.
I'm a pedorthist. I make a lot of high boots, and quite common, maybe The boot is indicated for like a collapse in the foot or a foot deformity, but there is also foot drop. And sometimes we try and make the boot, an L shape to help with foot drop, but is there a version of the brace that might deal with a higher, say a 6-inch boot?
That's a good question. Now, when you say the braces that you build, are you talking about like an Arizona type brace or like a?
No, so just the heel counters would be reinforced quite high up the boot and then attach and extend to the soling of the boot as well. So the shoe becomes quite L-shaped in terms of its rigidity.
Right. So this is a patient's own boot. You're doing. Do you mean shoe modifications or boot modifications?
No, that's just custom made shoes actually. So yeah, fully bespoke shoe. But I can see like a concept where I could perhaps lower the boot height to interface with an outside brace.
Right. Yeah, I think that probably be the thing, Chris. I mean, this is the concept is relatively applicable, kind of over a broad range of footwear, but there's not a separate version of the Elevate. So it would be, you'd have to kind of experiment with the existing brace, look for ways that it would interact with what you're doing. And yes, I think if you go a little lower on the top end to make room for the brace, because it sits comfortably. In fact, if you have a little higher rigid boot counter in the back, so the brace has a resting point, it actually would give you a better lever arm for a patient that needs more elevation on the forefoot, because you're a little higher up. So then your resolution of your vector there is going to be improved.
Yep. So something to keep in mind in the design. Yep.
We are looking at right now having a version that it's now patented. I don't mind mentioning this, but it can fit into the back of the shoe, just as a kind of almost like a shoe tongue would, and it will come up a little higher, and because it's sitting at the back of the shoe, it doesn't go under the foot. It just sits at the back of the shoe, comes up a little higher on the foot, and the BOA is in the back, and so you really don't even see the BOA from the front. We've had patients who've been trying it, and they, like one just said the other day, my mother-in-law, didn't know I had a brace, for quite a while, until I pointed it out, and so it's a little bit more discreet. That's a
non-circumferential concept. So
Yeah.
just posterior portions or elements, and then with the wraparound not going around the front, just the sides would have the attachment of the cords to attach to the shoe.
Yeah.
So if you can kind of envision that.
But the vector's been fine. We just thought that would be a little bit more discreet for some patients who appreciate that. But that's not really answering your question. I just wanted to throw it in because we've been working on it for so long and so hard.
And it does kind of answer the question too, though, Chris, because I think that might interact a little differently and maybe a little better with a higher top boot, because it would slide down as a tongue in the back of the boot.
Yeah.
All right. Any other questions at all from anyone?
I was going to say, as you think through questions, I mean, just in terms of patients where we've seen interesting stories, just to kind of give you an idea of the breadth of the patient population that I've been able to see it in my practice. It goes all the way down to, we've got a couple of young 20-year-old patients that had catastrophic knee ligament injuries that blew out their common peroneal nerve, and then wanted to remain athletic. One who played American football, but not contact, but we call it flag football. So it would have been kind of a variation of a field sport, but with the brace, was able to sprint, run, cut, and function at a high level with the brace. And so that was really thrilling to see. And then we've got patients that are, many of our even larger obese patients that have venous stasis disease and issues have been some of our happiest patients. And many of those patients can't tolerate an AFO, just simply because of the variation in size of their calf. It's changing, and they have a lot of perspiration issues there. And so this bypasses that, allows them to be able to wear something that gives them comfort. So that's been a really interesting and fun thing to see.
Yeah. The feedback has been the most satisfying part of the project. So
Some patients still love their rigid AFO, and for the patient that loves that AFO, it's a little more rigid, and this is maybe a little bit more work getting it on and off. That's probably where you're going to find a few patients that feel like they prefer that, but
Sure.
almost the vast majority that are looking for something different ultimately fall in love with this concept.
We do like the idea that that there's less atrophy around supporting muscles with an AFO that has a little bit more flexibility as opposed to a kind of a rigid shape that where the foot is put into a position. So that's helpful.
Yeah.
Well, thank you for the presentation, Rob and Chris. I really appreciate your time this morning, and thank you all for joining us this morning. This webinar is recorded, so expect a link to the recording in the next day or so. Otherwise, yeah, thank you all so much for joining us. If there's no other questions, we'll sign off.
Thanks so much, Steve.
Thanks, guys. Thanks for your time.
Thank you.